My name is Dr. Asifullah, and today I'm going to discuss arrhythmias and heart blocks. As for CVS II Module and cardiorespiratory modules of Khyber Medical University. So let's start. Arrhythmias, they are a failure in rate, rhythm, impulse formation, or conduction. All of you know that if the heart rate or the ventricular rate is too fast, that is more than 100 beats per minute, it is tachycardia. If it is less than 60, it is too slow and it is bradycardia. Regularity of heartbeat is of extreme and paramount importance. It can be regularly regular, irregularly irregular, irregularly regular, or regularly irregular. Formation of impulse originates from SA node, or if it originates from some place else, also defines the arrhythmia. And how the impulse travels through normal pathways or through blocks or reentry will give us the type of arrhythmia on that. Clinical PUL is an arrhythmia is not just an irregular heartbeat, it is any deviation from normal sinus physiology. What are the electrical faults that are classified predictably by rate, origins, and mechanisms? So, by the rate, brady and tachyarrhythmias, by origin, sinus, atrial, junctional, and ventricular, and by mechanism, enhanced automaticity, re-entry, or triggered activity. By rate, tachyarrhythmias are above 100 per minute, with palpitations, heart failure, and sudden death. Bradyarrhythmias have slow rhythm, they can cause syncope, dizziness, and also bradycardia induced cardiomyopathy. By origin, sinus origin, normal P waves from SA node, and if there are abnormal P waves, atrial fibrillation or atrial flutter, or some other place in atria giving P waves, they will be different in morphology from the sinus P waves. Junctional have absent or inverted P waves from AV junction, and ventricular wide QRS that is more than 3 small squares or more than 120 milliseconds, and it could be life threatening. By mechanism, enhanced automaticity has gradual onset and offset, for example, the sinus tachycardia, and re-entry, abrupt onset and termination like AV RT and VT, and triggered activity from early or delayed after depolarizations like in long QT syndrome and idiopathic ventricular tachycardias. The lower the origin of the escape rhythm, the slower the rate and higher the rate danger. So as you can see, as a nodal origin, the problems of sinus bradycardia and sixth sinus syndrome, the P wave is normal but heart rate below 60. Action is observed for permanent pacemaker if pauses are longer and symptomatic. In AV junction, junctional escape with 40 to 60 and his or Purkinje ventricular origin of rhythm may be idioventricular rhythm of 20 to 40 beats per minute. The rule of thumb is ventricular escape rhythm of 20 to 40 cannot sustain indefinitely and pacemaker is required as soon as possible. Should be implanted. Acute bradycardia management will follow a strict escalation protocol. First, you will follow the basics and appropriate action according to saturation and oxygen and airway, along with IV access and monitoring. You can give atropine every 3 to 5 minutes, minimum 1 milligram and up to 3 milligram. And if it doesn't work, pacing or dopamine or epinephrine or theophylline may be used. And definitive treatment is permanent pacemaker for high-grade blocks. The AV block diagnostic matrix dictates prognosis and intervention. In first degree, more than 200 milliseconds PR interval. Second degree, progressive PR interval prolongation and then dropped QRS. In second degree, Mobitz 2, constant PR and sudden drop of QRS. And in third degree, are AV dissociation or complete AV block. P and QRS are independent. Anatomical site of first degree heart block is AV node with excellent or benign prognosis, and in second degree AV nodal and usually benign prognosis, second degree Mobitz 1. But in Mobitz 2, his Purkinje, and it may be dangerous and high risk of complete heart block. And in third degree, AV node or below the AV node, and there is severe bradycardia. In first degree, may you observe the patient, and in second degree Mobitz 1, atropine. In second degree Mobitz 2, and complete heart block, permanent pacemaker is the management action. Progressive PR interval prolongation and then block versus sudden drop of QRS in Mobitz 2. The location of myocardial ischemia dictates the severity of resulting complete heart block. In inferior MI, the damage is AV nodal transient with excellent prognosis. P waves and QRS ignore each other, but the escape rhythm is often stable. But in anterior MI, complete heart block, extensive his Purkinje damage, poor prognosis, and permanent pacemaker is usually required. High risk of sudden ventricular standstill is there in complete heart block with anterior MI. So, tachyarrhythmia's diagnosis hinges entirely on the width of QRS complex. If tachycardia is above 100, QRS is narrow sinus tachycardia, AVNRT, AVRT, with WPW, atrial flutter or atrial fibrillation, usually supraventricular origin. But more than 3 small square are 120 millisecond wide QRS, monomorphic, polymorphic, VT, torsade, VF, and SVT with aberrancy. And the main thing is their high risk of hemodynamic collapse in them. So if you don't know what is the wide complex rhythm, you can say it is VT unless proved otherwise. Stable, regular, narrow complex tachycardia requires stepwise chemical cardioversion. First, you go for vagal maneuvers, then for chemical block with IV adenosine escalation, 6 to 12 milligram, and IV verapamil or metoprolol. And if the patient becomes unstable at any point, immediate synchronized DC cardioversion is an override protocol. Adenosine half-life is less than 10 seconds. It is administered via a large peripheral or central IV line followed by immediate saline flush. Always note that definitive treatment is catheter ablation in 95% cure rate for AVRT or AVNRT, but it is not the step 1 of treatment. Step 1 and 2 and 3 should be in the sequence rather than immediately referring for EPRFA. WBW is an anatomical bypass tract that is accessory pathway called bundle of Kent, and as you can see it is an additional, so there is a short PR interval with slurred upstroke of QRS and obviously a wide QRS complex. Any unstable tachyarrhythmia leading to immediate synchronized cardioversion plus less VT or VF is defibrillation in unstable patient. The AV block danger zone of Mobitz 2 and complete AV block will require pacemaker. The narrow and fast patient of SVT will require vagal maneuver and adenosine or verapamil. And the irregular patient, irregular atrial fibrillation, start with flutter waves, atrial flutter with variable conduction. Core clinical reflexes, Mobitz 1 PR lengthens until a drop, Mobitz 2 drop without warning, complete AV dissociation, MI location must be checked as well concurrently. Wide complex tachycardia is VT until proven otherwise. Delta wave and short PR is WPW, and WTW with AF, no AV nodal blockers, no adenosine and beta blockers. Pattern recognition saves lives and time. Immediate appropriate intervention will save tissues. That's all for today. Thank you.